Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Was it that way when you went through this whole process that everyone gives you different advice? How to choose a way, what schools?
Which schools for which ways? Dude, I thought that going to a place that had University of Utah ties was going to make a big difference, right? Like going to Baylor where the program director is Ganesh Rao, right? Who is the president of the CNS. Go there for rotation, get a good letter. Or go to USC, that's where Dr. Caldwell was a resident and faculty member and is good friends with Gene. So I feel like I got good. Like, do I see myself going to USC or Baylor? The answer is no. So I wish I would have done my ways. There are places where I actually would have wanted to go. Rather than looking for the name, I wish I would have looked more seriously about
Where I want to be.
Like, because my rank list, I thought was going to be like basically prestige, right? You're like looking for the name because your patients are going, right? And the person that went to Stanford, they're going to go to them first. Over someone else. But totally not true. My number one right now is Henry Ford in Detroit. And I almost canceled the year. All the schools that I thought were going to be amazing.
I'm so glad I had that last bit. Like I said, thank you.
Yeah. Dude, like I was so happy to go to OHSU. I was really happy to go to UVA and Baylor. Like I really liked the University of Michigan. And then I go there and the residents are just like pale white, not happy, not conversational. Yeah. And I was like, that's. And then I go to some of these other programs like Albany, New York, Henry Ford, Detroit, Medical College of Wisconsin, USC actually, but I just don't have the money for it there. But just some of these like unknown programs are some of the happiest residents I've seen.
inside human beings with 3D printed. I think that might be a way to decrease surgical burden of spine surgery. It's not there yet, but like that'd be cool to be able to work with stuff like that.
What do you think about step one being pass fail? Especially for your gear. There he is.
How are you?
I'm so good.
Yeah?
I was just with Jed in the ED.
Were you?
You showed me the picture of this big like spine fracture that he had sent
The
you.
L1 burst fracture?
Yeah.
Yeah.
That was nuts.
Did you see the stuff?
Mm-hmm.
Yeah.
I was like, that is awesome.
Yeah.
I can't wait to do that.
Yeah. Do you think you're moving towards spine?
It's either tumor or spine.
Yeah.
So I'm hoping that I can do a combination of,
Yeah.
you know,
I'm kind of trauma spine, which I think is just part and parcel of the experience.
yeah.
Um,
So for some people, that's like their worst nightmare.
I know.
And for us, I'm like, dude, I want that.
I know. Like that's the kind of trauma case that I would throw away.
Yeah, so like bilateral calcaneal fractures. Like, it's so bad.
Wow.
Dedication. So excited to submit in a week.
Have you sort
A week from today. I've certified twice and gone back and changed it.
Yeah. Everybody wants it. I want to go back and change something. But
Number one, if I matched at one of like my top 6, I would be ecstatic. Because nothing hits the process.
yeah, literally. Your number one is your role because it's
Oh, not.
checks it all the time. You're going to sacrifice one small thing. I really wanted to put USC as my number one.
But then my wife, she's created an Excel spreadsheet and showed me how much it would cost to live there.
This is making stuff. You should have seen.
Colin?
Yeah, there's that shit. No, I don't know. It didn't know anything about it.
Detroit.
Even when I told you that Lloyd just invites like the music dragon.
So that was actually allocated.
Oh, okay.
But I can't wait to see it. They had like happy lights.
Yeah.
Big part of that.
I'm sure that's right there.
No,
Yeah.
like it was. I
just want like
It's pretty low.
Yeah. I'm sorry, they didn't know we had the cheese. Oh, okay. Sorry, I was thinking earlier, but I'm just gonna go, look there, and then, you know, that's okay. So should I don't have my education box, so I couldn't use this computer. Never mind. You're good.
Okay, so far, I'm just like.
telling you that this, let's remove your breast because there is cancer in your breast.
I like your whispers at night.
What is that?
Better.
Oh shoot, I didn't do it. I didn't do it on by accident. No, I'm pretty sure I did it to design. That's the only thing I accidentally done, because I definitely did it for design. Unless I thought I was
Because you're
Yeah.
You ask questions like, nice, okay. It's not
Oh, you're running loose?
You get it's like, just that. It's so
All right, good morning, everybody. We'll go ahead and get started. A couple of announcements as per usual. Following grand rounds, there's an abbreviated indications conference this morning. I think Dr. Pache is moderating that. And then the chief residents will be off for some friendly discussions with some of the faculty about a few cases. Just, we're just going to talk about things. So for grand rounds next week, Dr. Roy Fediakorn will be visiting from Harvard. There's a symposium Tuesday night at the UofU conference room at 5 o'clock on feedback and evaluations. And then his grand rounds talk will be on resident autonomy and the power gap among students, residents, faculty, and that'll be Wednesday morning. The following week, Milos will conclude our chief resident lecture series. And then just keep on your calendar, faculty and resident education retreat is Wednesday, March 18th. Anything else? Oh, yeah.
Good morning, everybody. So I mentioned this in our GDC meeting a second ago, but Dr. Marula, Dr. Robbins, and I are happy to announce that version 1 of our virtual reality trauma simulation program is ready for testing. So look out for an email from me. This participation is totally voluntary. But Monday, Tuesday, and Wednesday of next week, we're looking to get about 10, 15 participants, MS3s all the way up to surgery attendings to participate in a pilot study of our program. You'll be wearing an Oculus Quest device with the handheld things and running through a fairly accurate virtual reality simulation of a trauma code. We're trying to get enough pilot data to get an abstract into the by the beginning of March. So look out for that email. Please participate. The program is super cool. I think we're one of the only institutions in the United States that's actually doing this. So we will do some groundbreaking stuff. Look out for that. Thanks.
All right, good stuff. All right, so for this morning, we have Dr. Lily Gutnick as our speaker for Grand Rounds. She is, after completing undergrad in med school in New York, she then earned her MPH from Harvard University Public Health and Brigham Women's. She'll be completing her residency here this summer, then moving on to Duke for a breast oncology fellowship. Looking through her CV, you can tell she's very passionate about global health. She's worked on advisory boards and research projects in India, Switzerland, China, Palestine, Sri Lanka, Tanzania, Ethiopia. I'm sure there's others. So she's fluent in English and Russian, proficient in Hebrew, and apparently still working on French. So she's going to be speaking to us this morning about breast cancer in sub-Saharan Africa.
Thank you for the opportunity to present today. So a couple of weeks ago, I was at the Academic Surgical Congress. Several faculty members were there as well. And the presidential address and the presidential panel was on the topic of purpose and finding your purpose in your career. So today I chose to talk to you about my purpose, and I feel I'm very fortunate to have found out pretty early in my career what that is. And it is this very big and daunting topic of breast cancer in sub-Saharan Africa. It's a huge topic, way more than an hour Grand Rounds presentation. So my goal here today is just to kind of give you a big 30,000 foot overview, and I'm more than happy to discuss anything in more detail later. So let's just first start talking about geography. What is sub-Saharan Africa? Africa is a continent, has 54 countries, 46 of them are in sub-Saharan Africa. So there's a clearly geographic divide, the Sahara Desert, and anything south of the Sahara Desert is considered sub-Saharan Africa. This region has over 1,000 languages, which is around 1/6 of the world's total. It has a population of 1.6 billion people. But besides geographic definition, there's very significant geopolitical definitions. So big governing bodies like the World Bank and the International Monetary Fund also have different regions in this area, and some parts are going to belong to the Middle Eastern region, mainly things in North Africa, and even some of the countries that are geographically below the Sahara, while others are not. And this has significant implication when you think about aid distribution and political priority setting. So taking a step back before we get into really breast cancer, let's talk about non-communicable disease. So you'll hear these words, anyone that's interested in public health or in global health, you'll hear this buzz term that non-communicable disease are now the shifting pandemic. And this has been recognized by the United Nations. And even though, although traditionally we think of pandemics like infectious disease, you think of things traditionally like HIV and malaria, the truth is that non-communicable disease takes significantly more lives annually than HIV, malaria, TB, and most other infectious diseases combined. They're the leading cause of death and disability globally. And in 2018, which is a snapshot of this figure here, the UN had a high-level commission meeting on non-communicable disease. This is the only health issue that the UN has had a high-level commission meeting on besides HIV in the last 30 years. Cancer is the second leading cause of death globally, and approximately 70% of cancer deaths worldwide occur in low and middle-income countries. So clearly there are significant global disparities in cancer in general. And so before I get into the landscape of my talk, I did want to share this brief video that I think will be a nice introduction. And I did test this before it works. Okay. So this was produced by the New York Times and published about 6 years ago.
The doctor told me that, Jesse, let's remove your breast because there is cancer in your breast. I said, I'm still young. How can I stay without breast? I may look like somebody who is mad or what. Yeah. By that time, I start getting difficult life. Yeah. There is a word for cancer. Sometimes they call it a Chui in Nachuri language. The cancer nowadays is a big problem. Sometimes they just think maybe the effect of the womb. They don't know. They think cancer can spread like malaria. If you live with someone who has cancer, if the mosquito bite you, they will spread for you cancer. People fear cancer better than AIDS. They told me that if you have AIDS, at least you can get treatment for free. I live in Gulu, northern part of Uganda. Gulu is far, very, very, very far. I received my treatment in Kampala, Mulago Hospital. Sometimes I spend 2 months there without coming back because there is no drug in Gulu. And Mulago is a big, 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 big hospital. But sometimes you will find when there is no drug in Mulago. Those who have money can buy. Those who don't have money like me, I just live there in the veranda.
So She mentioned a lot of the things. I'm going to get into it, but you could see that getting cancer care, getting chemotherapy, getting wound care in the Uganda Cancer Institute, which is the only cancer center for the entire country of 30 million people in just the capital, what it's like there and how different it is than here, and how lucky we are to be here at the Eastern Cancer Institute. So the rest of my talk, I hope to take you through a big breast cancer landscape in this region. So again, big topic, short amount of time, but let's just get started. And I will try to take you through the lens of sort of a patient journey from knowledge awareness all the way through palliative care, and then some big picture things like policy, advocacy, and research. So starting with epidemiology. So breast cancer is the most common female cancer worldwide, accounting for about a quarter of all cancers among women. Breast cancer is the most commonly diagnosed cancer in Africa, with approximately 200,000 new cases. It is the leading cause of cancer in women 30 out of 54 African countries. And while you can see on this graph here, the incidence in Africa and other low-income countries is lower than in high-income countries. Unfortunately, we see the opposite effect in mortality. So while Africa and other similar settings have much lower incidence of breast cancer than high-income settings, they have a significantly higher mortality. And when the mortality to incidence ratio is calculated, it's about 50% for most of these countries in this region. That is about 4 times higher than in high-income countries. As I previously mentioned, non-communicable diseases are the new pandemic. Developing countries are seeing a significant rise in cancers and breast cancer specifically, while high-income countries are seeing either a steady state or even a decline. So signaling the need for international community and local and global stakeholders to really take this issue seriously. This is a great graph showing 2 populations, Germany and Ethiopia, that has similar starting population. As you can see, the rise of breast cancer is projected to be much higher in Ethiopia and surpassing that in Germany, which is supposed to be settling out. So in high-income countries, we know that knowledge and awareness has been a significant component of cancer control policy and a significant reason for why there's been downstaging of breast cancer in countries like the US. But what's the situation in sub-Saharan Africa? So unfortunately, in many of these countries, knowledge and awareness is extremely low. This is a table from a large cohort study of breast cancer from 4 countries, and only 40% of the women believed that breast cancer was even common. 28% knew that the disease could be inherited, and 26% knew that lifestyle could be a factor. 18% knew that risk of disease increased with age. And only 53%, a little bit more than half, believed that breast cancer had any sort of curability. The same study also shows some interesting, strongly held incorrect beliefs, including things like trauma, infection, putting cell phones in your bra, secondhand bras, are causes of breast cancer. And then interestingly, despite the first presenting symptom often being a breast lump, only 10% of these women in this cohort thought that it could be cancer. Overwhelmingly, women thought that it was other benign explanations, things like clogged milk ducts, infection, or they really weren't sure what it was, but they weren't necessarily worried about it either. The most frequent cancer symptom experienced by women was lump and pain and swelling as well. So what about screening and early detection? So we know that's been a really important thing in the Western world of why we have most of our breast cancers present in early stages in 1 and 2. What's going on in sub-Saharan Africa? So this is a survey done by the Union of International Cancer Control back in 2007. It had over 40,000 participants from 39 countries. And it was a major survey based on cancer beliefs and behaviors. The African countries represented here were only 4 of them: Ghana, Nigeria, Kenya, and the Ivory Coast. And clearly you could see that only 5% of women in these countries have ever had screening mammography. And this trend is really apparent in all the other countries in sub-Saharan Africa. This is largely due to lack of availability of mammography screening. So in light of this fact, unfortunately at this time there is no population-based organized screening, and it's really not possible. Based on published research and expert opinion, several organizations have actually formulated guidelines of what else could we do. We can't implant mammography. It's just not feasible. So a lot of big organizations, the Lancet Commission of Health, Equity, and Women's Cancer, suggest that clinical breast exam is cost-effective and feasible. The WHO endorses that while screening mammography is not possible, clinical breast exams should be explored. And the Breast Global Health Initiative also endorses clinical breast exam in the lowest resource stratification. Most recently published in the end of 2018, the National Comprehensive Cancer Network and NCCN guidelines, which is a common set of guidelines we all use here, have actually developed a whole set of resource-based guidelines for both screening, prevention, diagnosis, and treatment. And even they advise that in the most basic resource settings for mammography is simply not feasible, they recommend clinical breast exam. But what about the actual screening practices? So even despite these recommendations, so the policymakers and the expert opinions and physicians are realizing we can't do mammography, we have to do clinical breast exam or other methods. What's actually being done? So this was a recent systematic review of screening practices in numerous countries in sub-Saharan Africa, showed a very slow screening prevalence. The highest mammogram use was only 7.8% and largely unavailable. Clinical breast exam, which is what's being recommended, is also anywhere from 2 to 23%. Fortunately, the most common thing that is being used is a breast self-exam, but even that has a wide range of anywhere from 5 to 89%. And we do know from large studies in the Western world that it does not, breast self-exam has good impact in terms of knowledge and awareness, but not really an impact on mortality the way mammography and other screening services have been demonstrated. So given all this, there's been other systematic reviews that are trying to identify what are the issues and barriers to screening early detection. Why are people presenting so late? So lack of knowledge and awareness and lack of screening are really the main drivers. There's other more individual, socioeconomic related factors, and then again, the larger health system issues and access to care. So moving forward to diagnostic phase. So when you think of diagnosis, I really like to use this trajectory. So there's from the onset of symptoms to diagnosis to treatment, what happens? What happens in a patient's journey? And there are many factors along the way that can influence that, and many reasons that can be attributed to delays. And so there's patient-related factors, demographic, socioeconomic, personal health beliefs, community health beliefs, psychosocial, and then health system factors, distance to facilities, health insurance, financial, diagnostic and treatment availability in the country. So these results are also from a systematic review of 21 studies in over a 16-year period of nearly 3,000 breast cancer patients exploring reasons for these delays. Of note, these studies are hospital-based from tertiary centers, thus excluding a large proportion of patients that never make it to the tertiary center. So the study shows significant delay in presentation in sub-Saharan Africa from when they notice a symptom to when they actually have initial contact with a healthcare provider. So a median time of 3 to 4 months, and in many countries up to 6 months. So you can imagine if you have a breast lump that's a cancer that goes undiagnosed or unseen even by a physician for 6 months, it will clearly quickly spread. But even after initial contact with the clinician, there's still significant other delay in diagnosis or treatment, giving another 3 to 6 months. In the US, for example, symptom recognition to diagnosis is on average 48 days. One reason for this delay is actually lack of knowledge among these clinicians, especially when they're first seeing these providers in the district level, in the rural level, and sometimes at health post. They do notice their breast lump. They do come in a reasonable amount of time. They get turned away with antibiotics. They come back because it's growing. Now they're given pain medicine because it's causing them pain. They come back again because now it's a large fungating mass. Now they get referred to the tertiary centers. That's hundreds of kilometers away, and they have no money and no means of getting there. Another important reason for delays is lack of publicly available cancer diagnostic service, where less than 60% of African countries have this resource in their public sector. So let's say we get past all that. Let's say a woman notices a symptom, it gets accurately recognized as something of concern by whoever healthcare provider she sees. And now you need to, ultimately for any kind of cancer diagnosis, you need pathology. Well, what's the pathology capacity in this region? Not very good. So as you can see, many countries have no pathology in the entire country, or even if they do, it says the highest amount of pathologists for an entire country of millions and millions of people is 4. Number of biopsies that are taken, which is the graph with the green shading, is also really low, where a majority of countries have under 100 biopsies performed on an annual basis for the entire country. Immunohistochemistry. This is very important, specifically in breast cancer, so we can know its receptor status and guide our management appropriately. It is available in less than half of the countries in sub-Saharan Africa. But again, moving forward, so all the women that were able to get through these barriers, were able to get their tumor biopsies, were able to get a diagnosis, what do we know about the tumor biology and genetics? Unfortunately, not very good things. There are high rates of triple-negative breast cancer, especially in West Africa. There are definitely very significant regional variations. This was an interesting study done comparing from a large biorepository of the US and in 2 sites in Africa, in Ghana and Ethiopia. They found that almost 50% of Ghanaian cases were triple negative, 43% of African American cases compared to white Americans had 24% triple negative, and the Ethiopian cases had the least of 17%. A similar study was done in Nigeria, also showing nearly 50% of the cases were triple negative. And there's been a number of small studies, mainly in Nigeria, Sudan, and South Africa, that were looking at BRCA mutations with quite significant ranges from 1% having BRCA mutations to as high as 56%. Let's look a little bit more granular, estrogen receptor status. There's a large systematic review and meta-analysis looking at receptor subtype. This is again from only 26 of the 46 countries that have reported on ER status, and fewer reporting on PR and HER2, which I'll show frequently. So there is a gradient, which the highest proportions of ER positive being in Southern Africa, especially South Africa, which does have a large white population, and lowest being from East and West Africa, so you could tell that here. Similarly, the same review looked at PR and HER2 status, and again, looking at much less PR and HER2 positivity in many of these African contexts. But interestingly, how does this compare to the rest of the world? How does this compare to the US, to the Western Europe, to African Americans and Africans? And as you can see too, there's really similar interesting trends looking at various European countries, looking at black-white disparities in the US, looking at black-white disparities in South Africa, and there is something about African ancestry that does have a predilection for more ER-negative status. So not only are a lot of these women disadvantaged from a health system perspective, but they're also disadvantaged from a tumor biology perspective. So needless to say, as everything I've just displayed, that 77% of women in sub-Saharan Africa present in stage 3 and 4 of disease. And this is a great slide. This is also a systematic review meta-analysis, 17 countries in sub-Saharan Africa, although it does comprise 71% of the total population in the region. Again, as I mentioned, 75% stage 3 and 4. But interestingly, as you can see, the lines below, that's looking at U.S. SEER data, looking at African Americans and white Americans over, decades-long period. Which still shows significant disparities today between black and white Americans in terms of stage of distribution, but you could see there's a downtrend. And so over the decades that we've been working on breast cancer in this country, we are seeing that there is a downstage effect, that women are now presenting at earlier stages, which is obviously favorable in terms of treatment modalities and morbidity and mortality for the long term. But we don't see that happening in sub-Saharan Africa. Things are still up in the higher corner of the graph. They're still significantly stage. So now that we've been diagnosed, what are the treatment options that are available? Let's start with some workforce. So as I've mentioned, the majority of women are presenting at later stages, so they really need medical oncology. They need systemic therapy. So unfortunately, there's a huge shortage of clinical oncology workforce. 8 countries have no oncologists. And 78% of the countries in sub-Saharan Africa have greater than 1,000 incident cases per clinical oncologist to manage. Whereas, interestingly, you could see in the US, it's less than 150 cases per oncologist. So what about chemotherapy? Fortunately, it is technically available in much of the region, which is great, but as you already remember seeing in the video, it's not always available. There's drug shortages, and even when it is available, it's largely available in the one tertiary hospital in the one capital city in the entire huge country of millions and millions of people. And unlike chemotherapy, which is generally available, there's huge lack of radiotherapy. Despite the World Health recommendation for a minimum of 0.4 radiation therapy units per 1 million persons, many African countries have 0. In comparison, the US has 12 machines per 1 million persons, so nearly 30 times the WHO recommendation. And then equally as extreme is the shortage of surgeons and anesthesiologists in sub-Saharan Africa, where the majority of countries have less than 1 qualified anesthesiologist per 100,000 people, and countries have less than 15 qualified surgeons per 100,000 people. Specialist surgeons, surgical oncologists, breast surgeons, virtually don't exist. Not surprisingly, when women do get surgery, this majority of them are mastectomies. But the surgical rates definitely vary quite greatly, from anywhere from 35% in Nigeria to 100% in Cameroon in this one systematic review. And the majority of countries report surgical rates between 48% and 75%. When it is performed, it's almost always a mastectomy. And reasons cited for low breast cancer surgery rates were attributable to inoperable advanced tumors, inability to pay for treatment, and patient unwillingness to have a mastectomy. Interestingly, this is a study I mentioned earlier in the knowledge and awareness section, this large cohort study of 4 African countries. And interestingly, even when treatment and workforce is available, there's still a significant proportion of women at all stages, including at earlier stages, that do not get treated within 1 year of the diagnosis. In Uganda and Nigeria, countries that don't have universal health care, financial barriers, aging and HIV status, and traditional health beliefs were attributed to these treatment gaps. In Namibia, interestingly, which is the country in the bottom, where you see them, almost all the women do get treated. This was a study from so first of all, there's universal health coverage, and cancer care, breast cancer care is covered, so the financial barrier is eliminated. This is the cancer hospital for the country. It's a tertiary referral center. And again, there is some level of bias because most of the time when women get to this cancer hospital, they are willing to get treated and they don't have any cost concerns. So given the significant rate of late stage of diagnosis, palliative care is critical to sub-Saharan Africa landscape. Most countries do have anywhere from 1 to 10 palliative care providers for the entire country. And there are a few outliers on this map, namely Uganda, Rwanda, South Africa have much more. Let's talk about pain management. So morphine is available in the public sector in about half the continent. The average opioid consumption across the continent is very low, ranging from an average of 1 milligram per capita per year. Mauritius, South Africa, Namibia, and Tanzania have the highest opioid consumption. The Lancet did a commission on palliative care and pain relief. And everyone knows about the opioid crisis here, but what is unknown is the opposite, the lack of opioid crisis in regions of the world that are underserved. So the Lancet Commission found that there are 298.5 million metric tons of morphine equivalent opioids distributed in the world each year, but only 0.1 metric tons are distributed in low-income countries, where 50% of the global population lives. So they ultimately end up receiving 1% of the world's morphine production. Indeed, most of these countries have a small proportion of morphine necessary to meet the estimate of palliative care based on serious healthcare suffering. And that's what this graph shows. It is trying to calculate the proportion of calculated healthcare suffering and drug availability. And as you can see in a lot of Western countries, especially in the US and Canada, there's significantly more opioids available based on projected need. And then you have a country like Nigeria that has 0.2% of the estimated need. And so to affect change, you need political will and disease priority setting. Let's start with big picture policy. So you need cancer control, policy planning and prevention. And unfortunately, about only a third of the countries in low resource settings have any sort of cancer policy plan in place. And this is important because this sets the agenda. This is going to set how you're going to spend your dollars, where you're going to spend your dollars, what's the most important on. Unfortunately, the truth is, a lot of healthcare funding in these countries are dictated by donors. It's dictated by outside funding and what the disease priorities are of the donors, not the disease priorities are of the country. And I think this is very clearly reflected in this. The first step to policymaking and disease priority setting is to have good data, starting with population-based cancer registries. I've shared with you a lot of data on epidemiology, incidence, mortality, statistics. A lot of those, unfortunately, were based from small hospital-based studies in tertiary care centers. It is obviously missing a large part of the population. And so here's just one map of the population-based registries. And you can see that very few countries in sub-Saharan Africa have any population-based registries, and very few even have any registration activity going on. So this is an important step. In order to decide what your disease priorities are, you first need to know what your accurate global burden of disease are for your country and how to spend your dollars. So in advocacy, the advocacy story in the U.S. is really amazing. Right now, breast cancer is probably one of the most well-researched and well-funded areas of cancer in this country. There's been a huge advocacy movement for decades and decades going on, pushing on this. And that has been a far reason why it has had so much clinical advancement and improvements. So there is some activity going on in Africa. This is a world map of Union of International Cancer Control Organizations. And there is, most countries have at least one organization, which is really encouraging. And things are happening and people are making change. So what about the future? So now I've kind of painted this very gloomy picture, and I want to share some encouraging initiatives that are happening now. The global health community is recognizing that non-communicable disease, and particularly cancer, as the new pandemic is existing, and people are taking notable action. The Breast Global Health Initiative is a joint venture from the Fred Hutchinson Cancer Center in Seattle, headed by one of their chief of breast surgery, Doug Anderson, and largely funded by the Komen Foundation. It works with low resource settings to create guidelines and education to providers. BioVentures for Global Health is a new entity developed in 2017. It is a public-private partnership that is working in 6 different countries in Africa. And it's really focusing on access to oncology medicine, technology, research, having these patients participate in clinical trials. And then most recently, in 2018, the NCCN has had a huge project in adopting its guidelines based on resource availability. They've now stratified everything from prevention, screening, diagnosis, treatment, based on basic resources, poor resources, or higher resources, what would be the ideal plan. All the major pharmaceutical companies in the world have also taken on cancer as one of their corporate social responsibilities, or in general their positive change initiatives to improve oncology care in low resource settings. And interestingly, it's not just about the cost of oncology medicines or delivering oncology medicines or supply chain. It's also everything on the cancer spectrum: screening, prevention, early detection, diagnosis, palliative care. And you can see breast cancer is definitely their #1 type of cancer cause and initiative. And sub-Saharan Africa has a number of initiatives, and some countries have even as many as 50. Many top academic centers and cancer centers in the U.S. are understanding this needs and are getting involved. Shown here is a recent symposium that was held in Nairobi, and as you can see here on the bottom, both MD Anderson and Memorial Sloan Kettering, 2 of the largest cancer centers in this country and arguably the world, have been involved, and they do have ongoing projects in various regions. They do also a lot of guideline management that's appropriate based to the resource setting, and training oncology providers and surgery providers there. There's not shown here, but other places, Barbara has a huge program in Rwanda with Butaro Hospital, which is just a cancer hospital in the rural region. So again, trying to eliminate some of these access to care issues and patients having to travel long distances and go to the main city. I mentioned earlier that Fred Hutchinson actually partners with Uganda Cancer Center, which is part of the video that was shown earlier. UNC Lineberger has ongoing commitments in Malawi as well. And this is a more and more of a theme. It's not like as much as a big commitments as far as like institutional levels, like some of these institutions I mentioned. A lot of cancer hospitals, academic centers are doing smaller cancer-specific projects in various settings. And then, as many of you know, there are significant disparities in breast cancer incidence, mortalities, and outcomes in African American and white women. You kind of remember showing back of several slides back, I showed the stage of presentation, and even today there's still significant difference between African Americans presenting at later stages than white Americans. And a lot of these times, even after you adjust for socioeconomic status or healthcare access status, you do see this change. And this is partly due to tumor biology, genomics, and genetics. And so to learn more about breast cancer predisposition, it could be related to inherited factors of African ancestry. So this map shown to the right of the screen with the arrows, this is a sad part of our history revisited back from the 1500s to the 1800s with the African slave trade. So where the arrows shown are where a lot of the people were taken from and brought to the U.S. And not surprisingly, when looking at certain studies, specifically in West Africa, and comparing the tumor biology, as I've shown earlier, the receptor status, the BRCA status of patients from West Africa, and comparing patients from African ancestry here, there's definitely significant parallels. I didn't get into it here in this presentation, but also there's been some studies done, and Lisa Newman, who's the head of breast surgery at Cornell, is really pioneering this work. In fact, this map was taken from one of her publications. It is really showing this strong linkage. And the NIH has realized this as well. So the NIH is funding a large, that is showing to the left, showing a large genomics and genetics-based study across various sites in Africa. Breast cancer is going to be one of the sites focused in Nigeria, but looking at this, we are realizing that there's important, in this global world, there's important genetic links and predispositions, and people are taking note and interest in studying this. Probably most of you remember at the conclusion of President Obama's presidency, one of his major initiatives was the Cancer Moonshot. And that was aimed to accelerate cancer research, make more therapies available to patients, and improve ability to prevent and detect cancers at early stage. But former Vice President Joe Biden really took on the leadership for this initiative, and one of his kind of sub-aims for the Cancer Moonshot was this addressing disparities in cancer research in low and middle income countries. His approach to this was to develop regional centers of excellence that would partner with institutions from the U.S. to help research and analyze these disparities. So of the 6 initiatives mentioned, 4 were breast cancer, and 1 was specifically breast cancer in sub-Saharan Africa. So I'd like to conclude with one of these quotes from one of my closest mentors, who's a American medical oncologist that has dedicated his career to cancer care in sub-Saharan Africa. And he said, shooting for the moon is important, but so is shooting for a world that is just and equitable. I went really fast, I apologize. I also cut the video short, but I'm more than happy to discuss anything in much more detail.
One thing that came to mind, you mentioned the lack of screening in Africa. Are there other, I mean, and I'm by no means a breast surgeon, so I'll defer to some of you guys as well, but are there other opportunities for screening using, clinical exam is helpful, self-exam is helpful. What about ultrasound, something that's fairly inexpensive, fairly affordable?
Yeah, so that's a really great question. That's a really great topic. So there was recently a big systematic review published looking at using ultrasound, especially in low resource settings. And they actually overall from pooled analysis found about an 89% specificity and like 96% specificity for ultrasound. So it's definitely a viable thing. Of all those, that was mainly, a lot of them have been done in Asia though. There's not been as many trials in Africa, but there is definitely something being actively researched and looked at, and especially there, I know there's definitely some studies in the works right now, particularly using the butterfly ultrasound, which is the portable ultrasound, so that's making things even more easier and less cumbersome. You just need like a smartphone, essentially. There's the ongoing studies right now looking at that as a screening tool, especially in the more rural settings. The whole thing with screening, I mean, that's like my very personal niche is screening and early detection, because what I want my big life goal, legacy to be is downstaging, which I think the key component to that is knowledge, awareness, screening, and early detection. There's a lot of interesting, innovative things on, but I think the most important thing, and when I look at these studies, or I've been asked to review actually even some of these studies, like from a grant perspective, is you have to have what happens next. So great, you're gonna go out, you're gonna get your butterfly ultrasound, it's gonna work, you're gonna find something out you're gonna eliminate the barrier of her going to like a major center, you're gonna go out there to her community, rural community, go find something, then what? How are you gonna biopsy? Remember I said there are some countries that have no pathologists. You need to have a biopsy. Who's gonna read the biopsy? Where is she gonna get treatment? I mean, if you're gonna diagnose her, but she's never gonna make it for a multitude of reasons to the one cancer center in the city to get it, are you really doing a service? And these are big questions and ethical questions and, all part of a complex health system. But yes, overall, I do think that, and it is a really interesting area of research and innovation, and I fully support it, but you have to think of it in terms of the big picture too. Actually.
Really, that was a nice talk. Thank you. You indicated that the industry is getting invested in this. What should they be doing?
That's a great question. I mean, the truth is everything needs to be done. I mean, as kind of like I showed from the overlapping parts of the talk, trying to take you through a journey, there's significant barriers and delays in every step. I think a lot of it is research and innovation, creating low-cost tools, I think the biggest barrier is when things are available, they are concentrated in one urban city. So what can we do to help eliminate that barrier? There's things going on with drones, there's things going on with portable diagnostics. Those are all in patients. Then the other part of that is then empowering the local health system for treatment as well. So you can probably, I think industry has a lot to do with portable diagnostics, eliminating needs for travels, things that's going to be easy and cheap and quick to do on site, but then someone is still going to have to know how to treat that. And that's the other piece.
So, after your fellowship, you hope to work in this environment.
Mm-hmm.
You mentioned some things that need to happen to achieve your goals. What's going to be your first, we know what the problem is. Mm-hmm. You mentioned some things that could be done to solve those. What do you envision your first year or two in sub-Saharan Africa to make a change? What is it that's the implementation you think would you try to work towards? And what would be your goals? I'm trying to think of this as here at Utah, we have a couple $100,000 grant now to look at breast cancer to make changes in Ghana. And so we're kind of in a process now with many of the faculty trying to decide with our local partners what's the basic steps that we need to start to make these changes.
Yeah, I think one of the most important things is actually training healthcare providers and not especially at the district level, at the health post level, because that is a significant, going back to that slide I had from acknowledgement of symptoms to diagnosis to treatment and that 6 to 9 month journey. The part that kind of really disheartens me the most that I think is an easy win is when they get to the healthcare provider to not be turned away with antibiotics and pain medicine, which was what happens overwhelming percentage of the time. So I think training the providers so they can recognize they could do basic breast health. And then the next step in that would be diagnostic pathways and eliminating barriers to diagnostic, doing point of care diagnostic, doing things that are easily transferable, even telepathology systems that are available in some things. And then also the knowledge and awareness piece. So really those early stages, because I think that's, like I said, 77% of women present in stage 3 and 4. So for me, downstaging is the goal. And the two things that I think are very actionable is on the patient side. So educating them, making them aware, knowing signs and symptoms of breast cancer, knowing to come to the doctor early, not eliminating fear and stigma, especially knowing if you do diagnose things early, it's not necessarily a death sentence. And then the second bit to that is educating providers, because I've seen it way too many times, and that's really heartbreaking, where women do come in time and they get turned away with incorrect management, and then they progress, and then it's too late.
When we look at what has happened in several other countries, like we look at what happened to China in the 1990s, that country contacted basically the American Cancer Society and said, we've created a registry and now we want to take action. Can you help us set up a game plan? So I think your slide where you mentioned, and hit upon the fact that most places in sub-Saharan Africa, most countries don't have any registry or any documentation of the cancer burden there. What is the international community, like at the conference that you went to in Nairobi, what are other organizations, what kind of pressure are they putting on individual countries to lay out that foundation as a first step? Because I think in order to create a game plan that's tailored for individual low-income, low-resource countries, we've got to have at least the minimal buy-in.
Yeah, no, absolutely. So there is actually a large African organization called the Africa Cancer Registry Network. It's supported by IARC from the WHO, IARC, International Agency Research in Cancer, and is exactly that. It is trying to help countries set up population registries, teach them how to do it. I mean, they're kind of, the problem is they're not a funding source, so they, like exactly the situation they described. So if a country like decides that having a population-based cancer registry is a priority for them, and they have some funding or availability to do it, they will then come to the African Cancer Registry Network and be like that, like, okay, you know, we've got this goal, we've got the funds, like, help us do it. So that is in place, but the problem is getting like the funds and the political will and buy-in to want to do population registries.
There's no real, there are no groups that are putting pressure on African nations to do this. I mean, because they have a global health burden that's rising, and lots of people are spending money at it in order to try to come up with, you know, some form of help.
Yeah. So yeah, no, I mean, unfortunately, like the African Cancer Registry is like, it has been developed sort of out of that need, but and it is like a metric, it is a WHO metric and indicator, so there's sort of that overarching kind of political need. Like in general, things are indicators are based on what people, policymakers think are the most important things to like have in place in your country. So there's that, but unfortunately, I mean, this is like the hugest problem in global health. It is like majority like vertical funding. So there's like big donors, there's like the Gates Foundation, the Clinton Foundation, Gavi, you know, XYZ, and like they decide if they want to give this money for this cause. And what everyone's doing now on the field is trying to leverage these platforms to then expand to non-communicable disease. Because in a lot of countries, there's a huge malalignment between the actual disease burden of the country, the actual disease priorities of the country, and their funding. So a country, Malawi, that I know very well, that I lived in the breast cancer work in, it like 70% of the burden of disease is non-communicable diseases combined. HIV is only 10% prevalence in the entire country. When I've worked with the Ministry of Health in their office, the HIV section has 30 people, and the NCD office had 2 people, the deputy and her assistant. So, and that's because almost all Malawian healthcare dollars are all external funding. They have very little internal health budget. And so when that's the case, they have to cater to that. So what people are doing, so like my mentor was actually really good at it. He's a medical oncologist, but he like ended up building this niche on like HIV-associated cancers, and then building this platform. So now he gets the HIV money because it's an ACD-associated cancer, but really using that money to build a cancer platform. Because if you get the chemo and even the basic things like the IV tubing and all that stuff to treat like Kaposi sarcoma or HIV lymphoma, you could also leverage that to treat breast cancer. And the truth is, on the ground, those are the workarounds that everyone's doing. But the big donors have not caught up to that yet. Oh, yeah.
No, my question earlier was, I think you answered and touched on it a little bit. Africa receives roughly $130 billion a year in aid, and distributing, allocating that, and getting it where it needs to. I think you just touched on that their aid doesn't always line up with their needs. Are there countries there that you think, or pockets of population that you think are doing it well and doing it right? And what would those be, and how do you model and expand that out to other places?
Yeah, that's a great question. I mean, South Africa is definitely an outlier, but also within South Africa is a big, diverse country. And I mean, the other thing too to remember, like I touched on this very briefly, is you know, not all of Africa is low income. So there's low income, there's low middle income, there's middle income and upper middle income. And like actually South Africa and Botswana are upper middle income countries. So they are not as reliant on aid to begin with. And I mean, I think that's the fundamental question, is you gotta build strong economies so they don't have to rely on aid, so they can use their own money, help align with their priorities. So obviously the countries that are ahead of the economic curve are also well off because they're not so reliant. So that's one of the big things. Rwanda is very interesting. Rwanda has been one of the largest African emerging economies in the last several years. They're very, their formal Minister of Health, Agnes Benwanahu, I'm sure Ray knows her too. That woman, I unfortunately had an episode to meet her one time. She is a force to be reckoned with. You need to have very strong leadership, and she was very strict. She set the disease priorities. And when donors came, she's like, these are disease priorities. You are welcome to support them, or if not, it's okay. And being able to say no to donor money, not every country can do that. And I think that's the key. So I think really it's just driving economic development and not relying on aid is the real answer, which is also the hardest thing to do.
And not everyone can do that.
Not everyone can do that.
So first I want to say that I'm really excited to see where you go and how this all turns out, because it's going to be fantastic. But related to Dr. Price's question, where do you think you're going to start? Are you going to be in Malawi? Or, what is your first step going to be as you go on this journey?
Whoever wants to hire me. Real answer. We'll see. But that is partly true. I need a paying job, so hopefully I can find that. But I do think Malawi is a real possibility just because UNC has a lot of investment in there. And there's been models of people doing what I want to do, like my mentor who's done it before, so there's avenues to do it. So Dr. Dugington was here last week giving his grand rounds. This wasn't part of his grand rounds, but I don't know how many people know. Indiana University has a huge program in Moi University of Kenya, and they actually have a permanent rotation of full trained board certified surgeons hired and living there for 2 to 3 years at a time, full time on the ground. A lot of that focus is really training the residents, building local surgical capacity for that region through Moi University. But actually the surgeon that's currently there now is a fellowship trained breast surgeon. She did her fellowship at Cedars-Sinai. And she does have a huge breast focus there, but she's doing, general surgery and everything as well. That would be another cool opportunity, but we'll figure it out. I definitely love research. I want to do a lot of research. I definitely want to write, apply for big NIH grants. So, my next step is I would like to, I'm actually research while I'm doing my fellowship about fellowship research that would then submit for a K award. And there is a Fogarty K, which is what I would like to do, which is protected 3 to 5 years abroad time. Yeah. So actually what I want to do in fellowship is I really love Lisa Neiman's work. I love the concept of global as local. We talk about that a lot too, and especially in a place like Utah, critical access hospitals, rural community. A lot of these issues parallel. We've talked about that, Dr. Matson and I, the patients 8 hours away in Wyoming who are eligible for breast conservation, but they have to be here for radiation, and they can't be here for radiation for 3 weeks, a month, whatever it'll take. So they'll just have a mastectomy. So there's similar comparisons, and I really I'm fascinated with Lisa Neiman's work about looking at the genetics and genomics in African ancestry as a driver of disparity in this country. But I think there's a lot more similar disparities, African Americans, vulnerable populations in the U.S. and sub-Saharan Africa. So I want to use that as a launching point. So one of the things we are doing, Duke has a biorepository in Nigeria, and there's molecular biologists looking at the breast cancer specifically. So we want to do combined also qualitative study, looking at their delays in advanced breast cancers and their experience of how they came to be diagnosed at an advanced stage, along with tumor biology, and finding the comparable cohort in Durham, because they do have quite a bit of neglected or advanced breast cancer as well, especially in the African American population, and drawing those comparisons.
All right, well, Dr. Thank you very much. Thanks everybody. 2-minute break, then we'll go with Dr. Shea. There's a value.
I'll be back. All right, I'll be presenting patient BR. And then we only have about 10 minutes to get through each of our topics, so we're going to go through this a little bit more quickly. So I believe this is a 17-year-old that came in with postprandial pain, weight loss. He had a past medical history that's shown there, nothing terribly significant. Because of postprandial pain and other things, so we had a previous open misidentification and a previous G2 placement on dexlansoprazole. Here's a bunch of allergies. One of the more interesting allergies that's literally listed in EPIC is food. Family history, nothing really significant, social history, and then I've got some vitals there. Just for the sake of, we should always start with a good differential for postprandial pain and weight loss. Front row, you guys can just all, as a group, shout out. Not all at the same time, but what are things that are in your very broad differential at this point? Great, so gallstone disease, septic ulcer, great. So neoplasm, great. Mesenteric ischemia, good.
And then you can take like irritable bowel or inflammatory bowel disease.
Yeah, wonderful. So really a broad differential. In terms of, so we're developing our differential, and then the next thing is, now that you have a differential, you're thinking about most likely things, and you're going to do labs and imaging studies and whatnot. I think since we only have 10 minutes, it's probably not in our best interest to go through all of that workup, but you're going to rule out the most common things. So you're going to probably get ultrasound, maybe endoscopy, and you're going to move through these differentials and not jump to some crazy zebra differential that this patient has. So that's like the main idea. Just always keep in mind what's the differential and then base your workup on that. So needless to say, this patient had all of those things, and then ultimately I'm going to show a couple interesting imaging studies, and then Mark and Lisa, I'm going to have you guys as a team help us interpret these imaging studies. So I'm going to show you.
Yeah. How'd you get to this point? Years of GI work.
Yeah.
It's usually like it's
15 different providers, Mayo Clinic, Cleveland Clinic. This kid is, so this is going to get very simplified.
Yeah, this is a zebra diagnosis that we're not all going to ever see. Yeah. So Lisa and Mark, I'm going to show you what imaging are we looking at, and I'm going to just flip through two different images, and I want you guys to describe some things that you're seeing.
The CT of the abdomen, pelvis.
With contrast.
And so one thing, we're at, you can see his G2 in place in the stomach. And then looking at the vasculature, there appears to be narrowing of
Yeah, and for the med students, how you guys deciding that that's the celiac based off of this very limited imaging that I'm showing you? Yeah, so it's the first big branch off the aorta, and then you can see the SMA is right below it. And so you guys is there any abnormalities with the celiac?
It's there's appears to be narrowing at the takeoff of the celiac off the aorta.
Yeah, so that is what's happening with this patient. Can you guys put a name to this potential?
Can you say, what's the difference between these two images?
Yeah, can you just describe in words, and then we're going
I need to say this because the images look different.
Yeah. So the images look different, right? So on this one, you can see that the constriction or the narrowing is less than on this image. So there's a difference between what we're having the patient do. This is inspiratory. This is an expiratory image. And I actually am going to have you guys think through why this happens in a moment. So anyway, to cut to the diagnosis. So this patient has median arcuate ligament syndrome.
So the other thing that you see on that image, not just the narrowing, but there's post-stenotic dilation, I want to say aneurysm, the origin of the celiac, proximal celiac axis. This patient does not have aneurysmal dilation or focal aneurysms of the lateral gate and the head of the pancreas, which you can see.
So the median arcuate ligament, this is a great kind of cross-sectional imaging that shows in Spanish the anatomy of this area. So you can see, and this is going to be relevant when we talk about the treatment. So here's the esophagus right here, and then you've got the crura, the right and the left crura that cross, and then immediately below that you've got aorta. So this is our arcuate ligament, part of the diaphragm that surrounds the aorta. In median arcuate ligament syndrome, normally that crossing of the diaphragm over the aorta is above the level of the celiac artery, but in this disease it is lower than normal, or celiac artery is higher than normal, and so it interacts with that celiac artery. So getting back to that imaging, once again, I guess I'll continue to pick on Mark and Lisa. So can you guys then describe, so this is inspiratory, this is expiratory. Why does that then make sense that there's going to be variation in the compression based off of inspiratory and expiratory, based off of the anatomy that I just described?
So as you inspire, the diaphragm moves caudally and will kind of, I guess, loosen those crural fibers. And then as you expire, it'll move cranially and kind of tighten them up, and that's how you get the compression of the celiac artery.
Exactly. And so that's what we're looking at the imaging. There's various diagnostic criteria for how to diagnose this. It just gets kind of complicated. It's not standardized. But you can see on your expiratory film, you should see about a 50% stenosis. If you're going to do more invasive things, you can get pressures, or a 10 millimeter of mercury pressure difference are considered to be diagnostic of this issue. Like I said, we only have 10 minutes, so let's kind of quickly dive in. So celiac, or the median arcuate ligament syndrome is first described by an anatomist. This guy, actually Lipschitz, I'm not sure if this is a picture of him, but this picture showed up when I Googled it. But he described this after a dissection of a bunch of cadavers. This is also known as Dunbar syndrome, who was one of the first surgeons to surgically treat this. In terms of clinical presentation, it's kind of what we described. Patients tend to present with abdominal pain, nausea, vomiting, bloating. Sometimes this is positional, sometimes it can be exercise-induced. In terms of diagnostic modalities, there's many that have been described. We focused on a CT scan. Can anybody think of an exam finding that would be interesting for this diagnosis? So you're seeing this patient in clinic.
Abdominal bruit.
Yeah, abdominal bruit could be an interesting exam finding. And apparently there's a triad for this diagnosis that I did not come across, but triad of, is it weight loss, postprandial pain, and abdominal bruit. So watch out for that on your exam. That shall probably be a discussion. But you can diagnose this by ultrasound, you can get CT scan, arteriography, you can get MRI, you can do more invasive measures. Apparently, people can do gastric exercise tonometry, where they put a catheter in your stomach and measure whether your stomach is becoming ischemic when you exercise. All this stuff has been described. Yeah, so we're hurrying up. So just because you get a call from the ED and a patient has this on exam or on the CT findings, this is extremely common on imaging findings. So like up to a third of patients can have some kind of a finding on imaging. A third of patients on cadavers, on cadaver dissection can have this. There's a cool study here that showed patients who are having chemoembolism of their liver, they measured pressures, and these were patients that did not have median arcuate, like normal patients. And you can see that 7% of patients met diagnostic criteria despite having no symptoms. So this is a hard thing to diagnose. The diagnostic criteria are unclear, but you need to have the right clinical picture. You need to have the right imaging studies in order to come up with this diagnosis. So in terms of treatment, I don't expect people to know the treatment necessarily, so I'm just going to kind of run through it. So the treatment is essentially surgery. You can pursue percutaneous interventions, but they've been studied and have not been shown to be very effective in this disease. So you, with the appropriate patient, are going to go to the OR. There are laparoscopic, robotic, open techniques that have all been described. There are considerations for intraoperative measurement of ultrasound flows, intraoperative imaging. There's a ton of different ways of doing this. I'm going to just describe the basics of it, which are essentially you go in and you are going to gain access to this part of the body and lyse the median arcuate ligament over the celiac artery. That's essentially what you need to do. Yeah, this is actually pictures that we took in the operating room. Getting to kind of dive in a little bit more, there are multiple ways of getting access to this area of the body. The way that I believe Dr. Glasgow, and the most common way that I was able to see online, is you approach this kind of like a standard upper GI Nissen paraesophageal approach. So you get in laparoscopically, same port sites that we use for those procedures. You divide the pars flaccida, you expose both crura. And if you remember the picture that I showed before, deep to the desiccation of the crura is going to be your aorta. So then you follow the crura deep until you reach the aorta, and then you travel distally along the aorta until you get to the celiac artery, lysing all of the muscular fibers on your way. Once you get to and I have a couple pictures of that. So you can see here, this white structure up here is the exposed aorta. You can see that this person is just marching down with their electric artery coming across the muscular fibers as they go down. Another picture. This one you can see exposed aorta marching down. This is the celiac artery. And then you need to circumferentially dissect the celiac artery out so that you know that you have fully decompressed it. And that's the surgery. That's the surgical approach. You can also go in through the gastrohepatic ligament to access the same space. Anything else to add, Dr. Glasgow?
It's just unique to this guy. His prior surgical history made it impossible for us to do this laparoscopically. It even took an hour and a half to find his aorta. The other principle is working towards yourself down the aorta is difficult. At some point you have to identify the celiac. The easiest way to do that is to follow the cephalad surface of the gastric artery and then connect the dots. My only other point of caution is that this diagnosis is currently being attributed. Everything in the world is being attributed to the median arcuate ligament syndrome. Trump being president is being attributed to and you have to be very careful. There's very little data to back this practice, and there's a lot of stuff being done, especially in our community, that's probably not evidence-based. The reason we chose this guy is he was very carefully vetted through reliable channels, and we really hung it heavy on him as to whether or not this would be effective. I actually saw him in clinic yesterday, and for the first time in 18 years, he's eating food.
He's not allergic anymore?
What's that?
He's not allergic.
No, he's still crazy. Careful. Careful.
All right, so Tyler Bender, you're filling in for Eric Weiser in Southern Colorado because he's telemark skiing for the week. And he's got a 35-year-old female with Lynch syndrome, and you see this at 10 centimeters from the anal verge, and it comes back with a tubular villus adenoma with high-grade dysplasia. What are your thoughts on next steps? This is in your colonoscopy practice.
My colonoscopy practice. I would be concerned that this is, incomplete or sampling error, and as I'm trying to work this up, I want to exclude the fact that there's like a higher degree of dysplasia or cancerous process that I haven't fully biopsied when I grab this.
Yes, it's got to go. Yes.
And so then as I'm talking to her, kind of setting up my planning for the next step, the additional things I want to do is verify that the rest of the colonoscopy was, no other lesions.
Nothing else.
I would also obtain, where was this at? Sorry, I know you.
10 centimeters from the anal verge.
So then I would need to also do the pelvic workup to see if there was any invasion nodes otherwise. When my
What do you mean pelvic workup?
Huh?
What do you mean pelvic workup?
Depth of invasion out. If this is, you said 10 centimeters from the anal verge.
So you order a test called?
I would get an MRI, but I also know on the abstract.
So you get an MRI for something that's not cancer?
Really?
Insurance denies it.
Okay. So, and then I also would further testing on the pathology that we got back if the sample is adequate with Lynch syndrome. I guess we wouldn't need to do that stuff.
Yeah, we already mentioned Lynch syndrome.
Okay.
Okay.
And then we talk about the different operations we have available.
Which would be?
We could do a proctocolectomy with like an ileoanal anastomosis.
Ileoanal. It's 10 centimeters from the verge, so you could do an LAR.
Okay. Or you can do a segmental, or you can do a total colectomy, or you can do a segmental resection.
Well, but we don't even know it's cancer, and Micah, are there any options that are less dramatic than that to start with?
I would rebiopsy this thing and try to get your diagnosis of cancer so you can appropriately stage this patient.
Rebiopsy, yeah.
You could do, you could do a rigid proctoscopy and try to reach this thing. You could do a sigmoidoscopy in clinic and do it.
So you do those things and it still comes back high-grade dysplasia.
What are the other options?
Transanal
So how do we do that?
incision.
Yeah, it's 10 centimeters. How are you going to get there?
I'd probably bring that patient to the operating room
And do
and
what?
then place them in cardiac clinic.
Okay.
You can do it laparoscopically, you can do it robotically.
Laparoscopic?
Yeah.
You can do a laparoscopic biopsy?
Well, sorry, not laparoscopic.
Proctoscopic.
Using your laparoscopic tools.
So what's that called?
I'm blanking on that.
TAMIS or TAMIS? Like you can go just grab, you can cut a big chunk out if you need to with the.
But I think.
Yeah, or you can do an excisional biopsy.
Yeah.
And just take it out.
That's not the appropriate treatment of this, but I want to get.
But it's that's
It is. If it's a polyp, for all you know right now, it is.
Yeah, it could be the appropriate treatment. So that doesn't preclude you from doing an LAR. So
Yeah.
So that's what we did. It was an open excision, Dr. Pickron closed with the robot, and we got back to we had a 3.4 centimeter cancer with negative margins, T1 in 0. We happened to get one lymph node somehow, not that we were really trying to, and there was LVI. So, what's that? Yeah, we did a partial TME, through the. Just kidding. That's not it. So okay.
But that is, it's an important question. If you do a transitional excision, you should get an infrarectal fat. You should get a full thickness biopsy.
So, Jim, so we've got T1 N0 cancer, N0 as far as we know, and with negative margins with lymphovascular invasion. This is a 35-year-old healthy female with Lynch syndrome. Thoughts on next steps? Well, sorry, before we get to surgical options, what staging would you get at this point?
So I do a CT chest, abdomen, pelvis, and then I'd stage the rectum with either ultrasound or MRI. I prefer MRI.
Great. So notice in this disease on the CT, couldn't see the primary tumor, surgical changes 10 centimeters, and there was a single suspicious node. Pathologist called suspicious, but not, kind of a hitch.
So you said Lynch syndrome?
Correct. So what are the reasonable next steps? If you were to give us the options that you think are actually reasonable things that could be done, what might they be?
So reasonable would be total abdominal colectomy extending down below this lesion
Sorry, did you say colectomy or proctocolectomy?
Proctocolectomy to include this lesion. And with working toward the J pouch would be reasonable as a first stage in a healthy person as well. You could also discuss, I don't think I'd recommend it, but just doing a proctectomy, LAR, for someone with Lynch syndrome, but I don't think I would recommend that in a young person.
So yeah, we thought the reasonable, so you said, just to clarify, so I think the second thing you said is a reasonable option, LAR, in fact that's what we did, we'll get to that in a minute. The other option would be a total proctocolectomy with J pouch. You would do the colectomy and the proctectomy all in one go in her, because really removing the rationale for removing the colon would be prophylactic. The lesion that we know about is in the rectum, so it wouldn't be in one go, and you'd be making a J pouch at that time. So there are, I guess, as it relates to any other treatment she may need, any chemotherapy and or radiation, there's a disadvantages to both of these approaches. Can anybody, try to reason out what they might be? I thought this was a really interesting discussion we had.
For final pathology necessitates radiation, you'll wish you hadn't had a J pouch.
Exactly, a radiated J pouch, you probably wouldn't. So you're kind of rolling the dice that if you found node positive stage 3 disease, especially with this, with this node that looks suspicious, that you would probably just be foregoing the appropriate adjuvant treatment. And then what would be the downside of just doing an LAR for now?
And eventually she'll probably need a colectomy, so that you might, just a few years down the line, be doing additional surgery.
Right, and if you find stage 3 disease there, she'll be getting chemoradiation, which is going to make it more difficult when you go to do the completion proctectomy and pouch, potentially in the future.
Yeah, that's kind of what I was going to ask. So, like, if somebody has suspicious node, I'm guessing you're referring to a multidisciplinary team, and then this question from that is it do you do neoadjuvant chemoradiation, and then one would probably total proctocolectomy with meningeoscopy, or where was that discussion before with a suspicious node?
Yeah, so they called this suspicious, but they were not, MRIs, they have templated reports, they were not calling this clinical N1. They were saying it looks a little funny, but this they stopped short of calling clinical N1. So we were treating this as fully clinically staged T1 N0.
Okay.
If it was, so if the suspicion was higher, then would another reasonable approach be to biopsy this, confirm, and then treat it?
Biopsy this node?
Yeah.
I'll defer that to our colorectal faculty, but I would think no.
Yeah, I mean, you can do that with endoscopic ultrasound. But then it's a tough question about whether you would do chemorads or not, or you do total neoadjuvant chemotherapy plus myelin. I wasn't as concerned about radiation with her because on her MRI, her total mesorectal, or her mesorectal fascia was clear. So I wasn't really concerned about locally invasive disease, but it was more just, I told her we kind of have to do the MRI because we kind of have to, just because Brett came. I said that we would basically take those findings, we would bring a salt, knowing that she's going to have reactive nodes, based on a recent exam. Had she had something that really, really looked concerning, then yeah, I think you do have the discussion of chemotherapy plus minus radiation, depending on what the rest of the mesothelioma fascia looks like, knowing that you're going to be in a J-pouch. But as Doug said, if I'm going to do a J-pouch on somebody, I'd rather radiate them, throw the nasty rectum away, and put a fresh J-pouch down there, as opposed to radiating a J-pouch. I would not radiate a J-pouch.
All right, I've got two more questions for you all. Stokes. So the rationale for, if you did a total colectomy her, you could say that it would A, decrease her chance of developing colon cancer, B, improve her overall survival, or C, both.
It would, A.
Correct.
It would decrease her chances of getting a rectal cancer, but it is not demonstrating survival benefit.
Yeah, correct. So just so everybody's clear on that. So the rationale, kind of read this in journal a couple of weeks ago, but the rationale for doing, somebody who has a colon or rectal cancer with Lynch syndrome, the reason you sometimes do a total colectomy or total proctocolectomy is to reduce their chance of getting a subsequent colon cancer. But as long as they're in good surveillance, there's not a survival detriment to doing a segmental resection.
As long as we're talking about prophylaxis, has anyone talked about the hysterectomy? There you go. Okay.
Question. So, anybody know the rectal?
Totally well hysterectomy. So, but what? Yeah.
Yeah. So the recommendation of these guidelines
At the time
was that people who have completed childbearing, there's a strong recommendation to consider this. It sounds like it was on the basis of one case control study where they matched people who had this and people who did not. There was 100% risk reduction in uterine and ovarian cancer by having these prophylactic procedures. And people who did not, who were matched, about a third of them went on to develop uterine cancer, and about 12% developed ovarian cancer.
Just for clarification of those guidelines, it's kind of backwards because it says if you have a colon cancer with Lynch syndrome, you should do a total colectomy. If you have a rectal cancer, then you have this discussion. So,
You guys gonna get your shit kicked out of you by a bunch of attendants? Sounds like fun. Let her escape and all that. She looks great. That's nice. Stroked it. Why are you here? Later. Can you yell a little bit? Are you back?
You did mine the first time. It's so late back then.
Okay.